Good evening, everyone. My name is Jennifer Hughes, and I'm the Chief of Staff at NAMI, New Jersey. Welcome to our webinar, Recovery from Schizophrenia, the Role of Clozapine. This special virtual presentation is co-sponsored by NAMI, New Jersey, NAMI Greater Bergen, and the Intensive Family Support Services, IFSS, of Bergen County. In today's webinar, Dr. Robert Laitman will be our speaker. He is a physician, lecturer, and co-author of Meaningful Recovery from Schizophrenia and Serious Mental Illness with Clozapine. Dr. Laitman became an expert in the treatment of schizophrenia and other psychotic spectrum disorders after his son's diagnosis in 2006. His goal is to change the way psychiatric care is delivered to those with severe, persistent mental illness and psychosis. It is his belief that the optimal use of clozapine can greatly enhance the outlook for this population. This presentation will highlight the importance of early intervention and share personal and clinical insights into what meaningful recovery can look like. Whether you are a family member or a professional, this informative presentation will undoubtedly provide you with hope that recovery is possible. Before I pass it to Dr. Laitman, I want to go over a few housekeeping items. This webinar will be recorded and will later be available on the NAMI New Jersey website and on YouTube, along with any resources. Participants will not be shown or recorded. If you have any questions or comments, please type them in the Q&A box, and we will try to answer as many questions as possible at the end of the presentation. We will not be using the raise hand feature. You are able to chat in the chat with everyone as well if you'd like to provide any comments or talk to each other. We do not provide CEUs or certificates of completion for attending this webinar. And at the end of the webinar, you'll be directed to take a short survey. We appreciate your feedback. Now we're ready to start. Dr. Laitman?
Thank you for that introduction, and welcome everyone. Again, hopefully, it sounds like the conversations have died down a little bit outside. So I'm right now in what is my dining room, and which is about as soundproof as I can get from everyone else. So I do believe that we can really transform the care for people living with psychosis. And I think, I'd like to start out first by kind of defining what the problem is and really understanding who we're talking about when we're talking about psychotic disorders. And I want to give you a very personal and a clinician's view of this, because I think most people really don't quite understand the population that we're dealing with. And why I'm doing this, because I was formerly trained as a nephrologist, gerontologist, and internist. I was actually triple boarded in those things. And then my life changed when my son developed schizophrenia. So that was back in 2005. So it's been a 20-year journey. This is my son, Daniel. And Daniel is a great example of what a lot of these illnesses are. So these are complex, polygenetic, not simple like Mendelian, where you have the two peas and you put two colors together and you get another color, but really a lot of complex genetics. And Daniel had a very tough genetic background, because I had a grandfather with schizophrenia, an uncle with schizophrenia, an aunt with bipolar illness, and then there was me. I was just talking to Jen earlier, and I was telling her about some of my running, and I've run 117 marathons, and that really was my treatment, because part of his genetic burden was me, in that I was a great student. This may sound familiar to a lot of you. Top of my class. And then all of a sudden, my junior year in high school, also at the age of 15, which is when Daniel got sick, I had a dramatic decrease in my scholastic aptitude. I pretended to be sick. I stayed home from school. It was a tough, tough year. Fortunately for me, my dad was an early adopter of running, and I started to run with him, and I've never stopped running since then. And by my senior year, my depression cleared, and I was back to being a very good student, and obviously went on to med school and so on, and have never really been depressed a day since. Having said that, I run still to this day over 50 miles every week. So what was this illness? It was probably, given my family history, a bipolar diathesis where I just had the depressive phase, and the rest of my life I've lived without depression. Some say I have a little bit of hypomania. But let's get to Daniel now. So Daniel was very different right from the start. And he was, my oldest daughter was walking, talking very young. Daniel could barely crawl at 6 months and really didn't walk until 18 months. And that reflects this illness's neurodevelopmental nature. He was given early diagnoses of just severe immaturity. He eventually started to walk. He was obviously intelligent, but he had a lot of attention deficits. And in fact, during some periods of his time, was treated for attention deficit disorder. In full retrospect, being that these disorders are neurodevelopmental, that was what we would call part of his prodrome. That's not where the full-fledged disorder is, but the early buildup to this disorder. And this is a large segment of our population that goes on to develop psychiatric illnesses, where they've had these other conditions and they get labeled and people don't realize what the risks were. And believe me, I should have known better. My eyes were closed. I wasn't thinking at the time. So time went on, and with an individual education plan and a lot of support, Daniel did very well, and he was very integrated into the psychiatric community. Then if you look at this picture, this is age 15. He was hearing voices at this point. We were unaware. And this is one of my cardinal rules for all my families. I say, check the guilt at the door. I felt guilty about not being aware of my own son's troubles, but I've learned it's really not useful. But you can see his arm is crossed across his chest. And that was because the voice was telling him to keep it that way. And, we thought we would have an easy time of it. Again, he was already seeing a psychiatrist, a psychologist. He told us about the voices. We went to the psychiatrist. He was started on an antipsychotic and quickly looked like Frankenstein's monster, became very stiff. He went through a series of 4 different antipsychotics, 3 at the same time. My wife and I started to read voraciously and found that this was not appropriate treatment. So 6 months into the illness, I was begging for clozapine. It wasn't going to be that easy. One of the rules, or some of the rules, is for people in medicine are you're not supposed to treat your own family. I've never been a real believer in rules that don't make sense. So I kind of asked my wife, who's also a physician, said, we've got to take care of Daniel. And eventually we did. We got a psychiatrist to prescribe clozapine, and his life was transformed. He went from having a transgender delusion where he had shaved his legs and was wearing a bra, for that to disappear, for him to barely be getting by in school, to ending up completing 4 years of college on the dean's list, moving into the city. The transgender issues went quickly away over the course of many years. Daniel is now 34, so he's 19, almost 20 years into this journey. And he is now engaged to be married. And as I said, his fiance is out there. He's a stand-up comedian in New York City. He's given large shows and small shows. It's a tough little profession, but think about what a stand-up comic has to do. He has to read the audience. So that's what we call theory of mind, being able to see what they're talking about, which is often a struggle. People with schizophrenia, he's got to be quick on his feet. He has to be able to memorize a lot of material, and yet also has to have good, what we call working memory, to get to the point where he can interact and change and be very, very, you know, very present. And he is a reluctant runner as well. And this is just one of our events where he was running. So, as I was saying, the schizophrenia, there are a lot of risk genes. And if you look at this, this is what's called a Manhattan plot. And the Manhattan plot shows the genetics of schizophrenia that were identified as of 2014. There are now probably over 300 genes that are identified. If you see the one really tall skyscraper, I just want to mention that. That is a gene that sits that has a lot to do with the immune system, which is also something that the brain and the immune system, they share a lot of genes. But this one reflects the expression of something called complement C4A. And this is a gene that ends up, and complement is used in your body to identify that things have to be removed. These are like foreign bodies, and your immune system in your brain, that immune cell is something called the microglia. And that leads to the removal of that tissue. And there is a condition where there's an overexpression of complement C4A that's responsible up to a quarter of the risk. And it's very interesting that clozapine, it distinctly dampens down the microglia and has effects. If you look at the rest of these genes, most of these have to do with the expressions, not surprisingly, of neurotransmitters and synapses. And these illnesses are whole brain diseases. I know we talk a lot about dopamine, and dopamine is very important, but there's transmitters for glutamate, there's GABA, there's acetylcholine, there's the entire nervous system that, has to do with obviously serotonin and norepinephrine. It goes on and on. Even the cannabinoid receptors are shown here. Now, this is a slide I want to spend a little time on, because when we make diagnoses in individuals, it's always like a snapshot. And really, a person's life is more like a movie. And so it's not atypical that people are given different diagnoses over time, but it's really the same person, and it is the neurodevelopmental nature of this illness. And when not appropriately treated, unfortunately, the neurodegenerative illness. So if you look at the top of the slide, that's reflecting symptoms. The blue are what are called the negative symptoms, and I'll talk more about that. And the red are the positive symptoms. The positives and the delusions, hallucinations. That's what usually brings people to physicians' attentions. The risk factors, as we already talked about, often the genetics, but there's also what we call epigenetics. Those are things that happen that will change your genes in utero and early in life. There are certain stressors. The second hit hypothesis, that is considered an epigenetic phenomena. Obviously, substance abuse, THC is a huge offender. Neurobiology, again, there is changes in synapses very early on. These are conditions that begin in utero. There's that altered synaptic pruning. So what is normal as you hit adolescence, you have the most synapses that you'll ever have in your entire life. And over time, there's what's called competitive pruning. I always like to use the example, I'm a Yankee fan. I like to talk about Aaron Judge. Well, Aaron just couldn't lay off the outside pitch. Low outside, he was a strikeout victim. But he's learned over the years, and it's just been repetitive nature. Stay away from that outside pitch and wait for your pitch, wait for your pitch. And that is an example of synaptic pruning. What's happened over time is the pathway that would allow him to swing at the outside pitch has been removed. And this is competitive pruning, whereas when the ball is grooved, Aaron's swinging. This is a normal process, and it results in a reduction of about 50% of all of your synaptic connections. So good connections are strengthened, bad connections are removed. In schizophrenia, especially with these people that have that C4A gene, there is an over pruning. And that's why typically these illnesses are really apparent in your teenage years. And then you start to see the disorganization of these pathways. You see gray matter loss and dopamine dysfunction. So the first episode is really driven by dopamine. And they come to your attention. If you've noticed the negative symptoms, and that would be like attention, focus, memory, typically started a little earlier. All the drugs work. So you give drug, the first episode is resolved. That doesn't mean the psychotic illness is over. It just means the positive symptoms have been taken care of. So typically when someone gets ill, they're not sleeping. They are quite what we would call manic, or they're using substances. So the first diagnosis typically will be THC-induced psychosis. You get them better. They come off of the substances. Well, they have another episode and they're still up and down and there's a mood component. Then we call it bipolar illness with psychosis. Over time, the negative symptoms continue to get worse and they become more thought disorder. Now we call it schizoaffective disorder. And then finally, over time, the positive symptoms kind of burn out a little bit, aren't as prominent, but the negative symptoms predominant. And now we call it schizophrenia. So these are the clinical features, and I want to talk about all of the domains. So salience is the ability to identify and to give meaning to something, and we use dopamine for that. And that's why you start to see delusions, hallucinations, and at the worst settings, catatonia. Dopamine's also involved in the reward network. And that is a dysregulated network. And the ultimate dysfunction there results in hopelessness and, unfortunately, suicidality. The things that are usually the most disabling for our patients with these psychotic disorders, though, besides obviously suicidality, is the negative and executive functions. So the default network is the negative the negative symptoms of schizophrenia. And that would include, that flat affect, not speaking a lot, the inability to get started, to have really that energy to move and do things, the lack of enjoyment, and ultimately the social withdrawal. And that social withdrawal is driven a lot by decreasing the processing speed, because to really have those social interaction, you need good processing speed. But you'll see executive functions diminish. They won't brush their teeth. They won't, they have trouble driving. They certainly have trouble staying engaged in work. Their memory and attention is bad. I've added comorbid substance abuse on the bottom because if you're going to include alcohol, cigarette, and THC as substance abuse, which I do, over 85% of our kids will go on. And psychosis, the actual thing of psychosis, is the detachment from reality that results in dysfunction. And dysfunction with work, dysfunction in interpersonal relationship, and in self-care. Now, I've recently added a sixth domain because this is what really stymies us so many times and really hurts our ability to get treatment, and where, fortunately, at least for me, Daniel never really had significant anosognosia. Anosognosia is the unawareness of the illness. And in that, just like all the other psychotic spectrum disorders, it is a spectrum of illnesses. So if you're going to really talk about the nitty-gritty, almost everyone has a little bit of anosognosia, but it affects about 50% or so of people with schizophrenia, so that they have actually no awareness of their illness. So would you take a medicine? Would you take insulin, for instance, right now, if you didn't have diabetes? So of course you wouldn't take a pill or an injection. So what drives this is this inability to be able to think about your own thoughts in an accurate manner. This is something called metacognition. And that just leaves you with a lot of inaccuracies, and you really can't assess your own functional status. And also, when you can't assess your own thoughts well, it's really tough to read other people. And if you can't read other people, it's really hard to have social interaction. That's called the theory of mind. A lot of this is there's a bias too. When you're interacting with the environment, you have to take in all this stimuli and you take in the information. Well, these kids have so much trouble often with perceptual difficulties that it is really much easier to take in an internal perception. So they tend to focus on that. And that becomes a delusion, which is a fixed false belief. It's extremely difficult, if not impossible, to argue someone out of a fixed false belief. For them, that is the reality. I like to say this resistance to this disconfirmation. It's really like talking to a wall. So, and this is where the rubber meets the road, is what happens when our kids have anosognosia and we have laws protecting their privacy. And a lot of you guys get closed out. Well, it shouldn't have to be. One of my rules is I never let Health Information Portability and Affordability Act get in the way of my care of my patients. And this is where you have to understand your rights. And unfortunately, the psychiatric community does not get this at all. HIPAA was never meant to take a family out of the care of their patients. That's not the goal. It was actually supposed to protect your privacy, from basically, this law came in 1996, just as a lot of things went online. So it was more about that, protecting your, your information from the online community. So what this says is really important. Again, where a patient is incapacitated or not present, and that means mentally as well, a healthcare provider may share, and it's based on their best judgment. There has never been a prosecution of any doctor that has shared information when he has felt that it is in the best interest of the patient to do so. And I worked with a lawyer in New York by the name of Laura Brancato, and she shows this to people and said, do you have more of a chance of being sued by the patient or your son, your daughter that's presently in the hospital that is really unaware of their illness and not functioning on any level? Or do you have a better chance of being sued by me when you don't give the information that we need to take care of him and he gets discharged and harm comes? So I will use this. I always start with a carrot when I'm trying to get information, but you do have a stick. So let's talk about the onset of psychosis. The standard of care is to go after the positive symptoms, and that is subcortical dopamine dysregulation. And it does work. As I said, all of these antipsychotics work. For them to work, typically there's several classes of antipsychotics, but of all the ones, except for the dopamine agonists, which bind more than 60 to 80% for them to be effective, and clozapine and the newer class, which is Cobenfy, and clozapine only usually binds about 40% or less. These other antipsychotics have to bind 60 to 80% for them to show efficacy. It doesn't mean it will work, that it will make your kid better, but you kind of have to get to that level. And that is what we call good enough care. And that's only the positive symptoms. In terms of the negative symptoms, unfortunately, most of these antipsychotics tend to worsen those. And this is just the list of all of those first generations. As I said, the aripiprazole, brexpiprazole, cariprazine kind of stand out a little bit because those are the dopamine partial agonists. And the rest are very much, even though we call the first generation, which doesn't have much effect on serotonin pathway, the second generation does have more of a serotonergic effect, 5-HT21A blockade, and that does somewhat mitigate some of the movement disorders that you have. And so what happens if you go too high and you get above 80%, pretty much everyone gets stiff as a board. Basically, you're taking out dopamine too much and they get Parkinsonian. And this is what I would say the standard of care, and we call that good enough. And I don't think it's doing the job. And that's finally, we're going to get to the body of my talk. And that's using clozapine in treatment-resistant schizophrenia and other persisting psychotic disorders. I just feel like I had to give you that background so I understand where I'm coming from. And there is a treatment approach that works. And I've labeled this approach. This is a paper that I published in Schizophrenia Research with Maturi Keshavan from Harvard. And he actually came up with the acronym, and I'll give him credit for that, the E's. But these are approaches I've been using for the last 20 years. E represents early intervention with clozapine. A is assertive monitoring. That means doing therapeutic drug monitoring and managing predictable side effects. There's this false choice where, what do you want to have, your body or your mind? I'm an internist. That you need them both. And then also what I mean by managing, I always tell my kids the drugs don't make you better. The drugs allow you to do the work to make you better. That means you have to do the cognitive enhancement treatment. You have to do cognitive behavioral therapy that's psychosis informed in many settings. There is, just a whole series of things that must be given to these kids. You diet and exercise, just socialization and normalization and so on. There has to be wraparound services. And then the S is slow. And I specifically mean for titration of clozapine. One thing we learned early on is the PDR is wrong. I just was co-author of an article requesting changes in the PDR. They did not make all the changes we wanted. But their titration is way too fast. Psychiatrists typically don't have a lot of patients on clozapine. They go to the PDR, and it's about 7 times as fast as it should be. And we have changed that, and we've taken it so that our patients started on clozapine as opposed to the typical patient, which about 50% will come off. We have a 94% retention rate once we get past the first month. First month is more about the E in this, and that is engagement. You cannot use clozapine unless you really have the patient engaged. The worst thing you can do with clozapine is come on and off and on and off. And the family has to be available for support. Clozapine is not easy, but I'm going to show you why it's so important to use as opposed to the other agents. So E, let's start with E. So these are the early interventions with clozapine. This is the evidence. The actual American psychiatric guidelines are only 2 antipsychotics, and I could live with this. A trial of 2 to 4 weeks given at adequate doses. If you don't have a response, or they're not even getting remotely close to where they were before they became ill, you need to consider clozapine. The other major indication for clozapine is suicide prevention. We lose 90%. We lose anywhere up to the highest number in the first year. It's more like 2 to 3%, but there was one study that was 5% loss to suicide. Clozapine reduces that suicidality by 90% compared to the other antipsychotic. The treatment response and resistance in psychosis working group, which I'm also have the honor to be part of, is a little more conservative. Kind of like the APA guidelines, again, 2 antipsychotics, 6 weeks, making sure that it's a 600 milligram chlorpromazine equivalent. That would be equivalent to about 300 of clozapine, 20 milligrams of olanzapine, 3 milligrams of Risperdal. I can take you down the hit list of all of them if you're really interested, and 80% compliance. The other thing that tells you that you need to be on clozapine is if you start something and it doesn't work, even the first episode, if you really get to therapeutic levels and you're 2 to 4 weeks out, the chance that the next drug will work is significantly less than 5%, except for in one study of 59 patients where olanzapine was at 7%. And the other thing, and what I find a true sin in the United States, where basically it's anywhere from 4 to as long as 10 years, depending on the study that you read, before people get on clozapine. The outcomes are not as good the longer you wait. Time is brain. So early intervention, it doesn't mean that you shouldn't try clozapine. It just means you're going to have to wait a lot longer. And further evidence was the Finnish study where they took the first episode patients and 71% of these people relapsed. And what they found is that if you switch to clozapine after the first relapse, you had a 34% decrease in that incidence. And if the patients were not on antipsychotics at all, which some first episode psychosis programs try to do, then you had a 45% reduction of having another relapse after that. If you switched to a non-clozapine antipsychotic and you were already on another antipsychotic, there was no benefit. And if you switched off of clozapine to another antipsychotic after a first episode, you doubled the risk that you would have another relapse, again, represented by the hallucinations, the delusions, the positive symptoms. This is what I mean by assertive monitoring. It allows you to confirm, one, that they're taking their medicine. With anosognosia, a lot of these kids will try to hide, and I'm a big believer in direct observation. We want to also get to optimal therapeutic levels. A lot of you have been told probably if you go on clozapine, oh, he's at a good level. It's 350. I don't want to push it up any more than that. Actually, the reality is there's a good literature that shows the treatment response continues to go up as high as 1,000 nanograms per mil. The problem is the side effects become more difficult to manage over 700. And that's why I think a lot of people are really reluctant to take this initiative. What we really talk about is rational polypharmacy. And I'm not talking about using multiple antipsychotics. I'm talking about taking care of predictable, absolutely predictable side effects and managing them. For instance, just to give you an example, clozapine will take a normal bowel transit time. That's time it takes from the time you eat something for it to come out in your feces, which is normally about 24 hours, and extend that to well over 100 hours. So you need to treat that. You need to use stool softeners. You need to use laxatives. We use a lot of Colace, Dulcolax, and Miralax. Weight gain, it has effects on hunger. It has effects on histamine receptors and serotonin receptors, and it really lowers GLP-1. So you tend to gain weight unless you mitigate those changes. And so we are very aggressive at early intervention. And this has become now the Maudsley guideline in London. I'm very happy because I've become very friendly with the guy who writes this, a gentleman by the name of David Taylor. And he finally added metformin should be started at the same time that you start clozapine. But we use GLP-1s. And it's really been a huge game changer. The salivation is something that you have to keep an eye on. With clozapine, pneumonia is a big risk. It's the constipation and pneumonia are the two things that I really worry about. And that can be mitigated. There are topical drops you can put under your tongue at bedtime that will stop that. The fast heart rate is something that can lead to heart failure. Again, something you can take care of. There are other cardiac issues as well, but going slow mitigates that. Seizure risk is another one. It sounds menacing, but it's all treatable, and I've been doing it all these years. So the other thing is to add, and then stuff that you don't like to talk about is bedwetting. Again, totally preventable just with doing behavioral modifications, not drinking an hour before bedtime. And then we use a short-acting form of anti-diuretic hormone. It does. It is complicated, and this is why you need the family involved. That's why you have to do the medicine. But I am telling you, it is worth it. And then you add the wraparound services and befriending, diet, and exercise, and you can have miracles. Again, slow, careful titration. We give as much as we need, but we try not to overly sedate. You do not want to have a zombie as a child. They will have an excessive need for sleep. There's really no way around that in the beginning. But just taking your time helps you find the optimal dose, and it really minimizes the myocarditis and neutropenia. My wife and I have been involved with almost 500 patients now. We have never seen a case of myocarditis or a clozapine-induced agranulocytosis. What's really nice is we went to the FDA advisory board last November, and with the Angry Moms, which kind of came from the Team Daniel group, led by Rachel Strife and Sue Maida, we all testified. And as some of you may be aware, there is no more mandatory blood work. Having said that, severe neutropenia can occur, and it is more common with clozapine. At least it's more common with the current titration schedule that they recommend. The risk is about 0.3%, but 90% of that risk is in the first 18 weeks. So I still recommend doing the blood work, and I think it's a good idea to do the blood work because you want to monitor and make sure that they're taking the medicine as well. But when we treat, we don't do 25 milligrams every day. We start at 12.5 milligrams. Usually that's it for the first week, depending on where they are. And we only increase by 12.5 every 3 days. Typically doing this, they're on another antipsychotic already. We don't stop that antipsychotic in the beginning. We only start to cross taper it off once we have clozapine around 100 milligrams and are starting to get levels. A big mistake that a lot of psychiatrists make is they stop the other drug and start the clozapine. The problem is it takes time to get clozapine to adequate doses. So you're essentially leaving your child in the midst of a psychotic rebound because they don't have adequate treatment. And we're going around trying to teach this to psychiatrists. It's one of the more egregious problems that I've seen. And then engagement. And as I said, you can't even get started with clozapine until you have engagement of the family. And again, since 40–50% will have anosognosia, you often may have to resort to involuntary treatment. But we always start with Javi's approach, Javi Amador, and that is the LEAP approach. It's interesting, Javi has joined an initiative because I'm trying to expand this approach. We've started another company because I certainly can't take care of the world, and I've actually stopped taking new patients because at one point I was personally taking care of over 200 patients, and I've been training nurse practitioners. And the group we have is something called Dora Mind. Javi was just on a podcast called Schizophrenia, 3 Moms in the Trenches, and that just came out today. And we're taking his LEAP approach and using artificial intelligence to make it seem like you guys have Javi in your back pocket. So this reflective listening, making sure that the patient feels heard, followed by trying to develop some empathy, finding something that you guys can agree and then partner on. And you can use the artificial intelligence. It is coming up on the Dora Mind site. It's, I believe, being launched now. So that is something for you to look for. But I'll tell you, sometimes it doesn't work, and I am not shy about getting assisted outpatient treatment. It sounds vindictive, forcing care on people, but it's not. I always say it's terrible to let your kid basically sleep in the street, die with his rights on. And I see that too frequently. And part of anosognosia is not being aware of what you really want or need. Again, you don't have that ability to self-assess correctly. So that may be the desire that they're expressing, but it's certainly not in their best interest. The New York laws are a little different from the New Jersey laws, and we just had a recent update. Thank you, Governor Hochul. So it's still 2 or more admissions with documented non-adherence over a 3-year time period or violence. But it's also now, if the person is refusing to take medication and is showing deterioration. And you can get a order to pick someone up and have them evaluated in the emergency room for a 72-hour hold. Again, the family must be involved. We unfortunately don't have a mental health care system. This is one of the things I'm trying to develop with Dora Mind, and we're trying to get this approach out there where we give adequate support. But I use my families to help me, and therefore I never let HIPAA get in the way. They have to be involved with the care of their children. It's just so difficult to do a clozapine regimen right unless you have that family involvement. Now, some of your kids live in housing that's supported. Same thing, then I bring the supported housing people in. The other thing about the AOT laws is it's also provides other service. So you have someone that's a care coordinator, that's another set of eyes. And then what's really important is we engage the family and the child in a non-medical setting. Every other weekend during the summer, I have my families come to my house, and you guys are invited as well. We have several families from New Jersey that come up to my house in Westchester. The other weekend, we'll do Zooms, and you're invited to that as well. I'll give you all this information at the end if you would like it. Give you my address, 6 Winkler Farm Road, Bedford, New York. You can look that up. It's being recorded. We really encourage NAMI, and I'm not just trying to pander here. We really do, family to family and all the support that comes with it. It's a very important thing. The one really big treatment effect that we find when we get in family and you do family education, that translates out to your child doing better. The more you know, the more you're involved, the better your kid will do. All right, so this is our approach of psychotic disorders. It's all about clozapine, engagement, and community. Can't stress it enough. I'm a big befriender. I am not a therapist. I'm not a psychiatrist, but I believe in befriending. I believe in normalizing. Again, I will use clozapine first. It's unusual. The vast majority of our population was on clozapine even coming to us, and they basically wanted us to manage the side effects. I've seen very few people come to me de novo. They're usually going somewhere else in the psychiatric community on something else, but I will use clozapine first if I have that. Do I have overwhelming data for that? Absolutely not. But in no setting has clozapine been shown to be inferior. And I'm not afraid to use it. You know, we talk about the other side effects, but the one side effect clozapine does not have, which is enormous, is the movement disorders. Tardive dyskinesia does happen with clozapine, but it's exceedingly rare. And that's really, really an important bonus. And again, as I said, we believe your family member has the right to be well. We don't tolerate side effects. And that's the other thing. We don't believe good enough. With clozapine, we want meaningful recovery. We want our patients returning to their pre-illness baseline. Psychiatry never believed in this. They have a nihilism. I was not going to put up with that with my 15-year-old son. Then when I did it, I was challenged to do it again by actually the gentleman who wrote the section on psychosis in the DSM-5. So I've been at it for, as I said, the last 15, 20 years. Community, engagement, communication. We've got to get past the learned helplessness and hopelessness. We believe in optimism. What do you do with the monitoring? We follow the levels. I do a decent physical exam, but what I need, so I have a lot of people that are on Zoom. We have kids in over 27 states that I take care of now. And we always want their weights, their blood pressure and pulse. So that's just the base. Excuse me, that's the basic. If available, a baseline echo, EKG. I like to do a little bit of an inflammatory workup. So I start with something called an HSCRP, a C-reactive protein. This measures inflammation in your bloodstream. I'll also do NMDA receptor antibodies as part of my immunologic workup. I've been recently adding an evaluation for Hashimoto's thyroiditis, because that's another cause of an inflammatory state that looks very much like schizophrenia, but the treatments are different in that you can treat them with immunosuppressive and get a lot of these kids back. And conceivably, if you get them early enough, they won't need to stay on neuroleptics. Also, before that, I always get a measure of their metabolic status, including their lipids. Hemoglobin A1C is a measure of sugar. I do a lot of urine toxicology because with the legalization of THC, that's where we have our failures. So when I can't get these kids off. And there is a new test out. And for full disclosure, I have very small ownership in myogenes, but it is a useful genetic test. It basically measures four things: the chance of success. There are certain genes that would predict that you would do exceedingly well. The lowest chance of success with clozapine by this standard was 20%. When Daniel did the test, he supposedly only had a 40% chance. Even saying that, if you compare to all the other antipsychotics, it's three times as good. But if you have a certain genetic subtypes, the chance of success with clozapine could be as high as the mid-90s. And then it also evaluates the risk of severe agranulocytosis, which is the very low neutrophil count, the white blood cells that help you fight infection if they go below 500. And then it also identifies those kids that typically run very low white counts. And that you'll find in well over 50% of people of color. And then finally, it will do the pharmacokinetics and the metabolism of the drug. We are recently added two more components, two more tests, both looking at the risk of something called a COMT and AKT3, I think. I'm not sure about the second gene, sorry. But they help you define what your risk of developing psychosis is with THC. In some cities where the THC, for instance, is so high in Amsterdam, the thought is that 1/3 of all the psychotic illnesses in Amsterdam could have been prevented if the person had not been chronically using THC. And as I said, the dual diagnosis, so important. I do the tox screens every week in a lot of these kids, and I check the cotinine levels, which gives me a degree of how much they're smoking. This is a little old, this data. This is from 2022. I actually we have a film called Into the Light, Meaningful Recovery, and we presented this film for the medical students at NYU several months ago. And one of the medical students called me up and has now become my little research coordinator. So I'm working now at actually gathering the rest of the data. This one I gathered with Rachel Strice's assistance in February of 2022. So it is pretty old, but as of that time, we had a 94% continuation rate. And again, as I said, we're not a first episode program. As you can see, over half the people already came to us on clozapine. But we take care of the sick of the sick. And, we take care of schizophrenia, schizoaffective disorder. So you look at it, that's about 3/4 in the schizophrenia spectrum. But we do also use clozapine with bipolar with psychosis. The other people will include borderline patients, people with what really does look like psychosis secondary to THC, or other psychotic illnesses, like, for instance, depression with psychosis. Now, meaningful recovery is not something that happens frequently, we think, in psychotic disorders. Very interestingly, and I don't have this as any of the slides, a recent study looking at the Suffolk County experience with the first episode psychosis program, looking at the people with schizophrenia, they had only a 1% people in meaningful recovery at 20 years past illness. This is how we define meaningful recovery. We want our people engaged in things. So we say we want a hard outcome, 20 hours a week. We want them in school or part-time work, maintaining a household, and say, how likely is that? I'll tell you, one office visit 2 weeks ago, the first two people, one came in with an engagement ring on and a wedding date. The next person was the guy, and he was showing the ring that was being made. And later in the day, I had a third who said, well, this Sunday, I'm planning on getting engaged as well. And that was only 3 out of 15. That was a little unusual, but homemakers, parenting, I see it. I've taken kids through pregnancies with clozapine. I've gone to weddings with kids on clozapine. So it does happen. We want them, they can be participating in a vocational training program. They can be a volunteer for 20 hours. And as I said, in the literature, remission and recovery are rare. This is the best literature, 2013, big meta-analysis, which just groups a lot of the studies together, and it was 14% were a meaningful recovery. New Zealand, where they have a pretty high use, in the United States, the use of clozapine is liberally in the schizophrenia population at 4%. Those are the people being treated. Half of all people with schizophrenia get no treatment, so it's 2%. It's hardly, if ever, used in the bipolar population. So if you look at the entire psychotic population for the United States, it's less than 1%. New Zealand, it's around 33%. And look at the recovery rate, 37%. When people came to us, our recovery rate was 26%, kind of in between. But if you remember, half of our kids were already on recovery. After 1 year on clozapine and given the wraparound service, we have 73% of our kids in meaningful recovery. Does not mean remission. Doesn't mean remission is the absence of symptoms. We believe you can live with a little bit of the voices as long as you can recognize it. And it's more important to have function. It's more important to become part of society again. Oops, that was our definition. How have we done with hospitalizations? I'm sure you guys have been in and out of hospitals. There's some of our kids that have been in as many as 60 times. At least 93% in the year before they came to us had been hospitalized. The hospitalizations are almost universal. The only one that I am unaware of that has never been hospital overnight is Daniel. And that was just because Ann and I would watch him every single night and take turns and not let him out of our sight. After 1 year, our hospitalization rate, 15% or less. And some of those were for mental health, some were for adverse side effects, and a few were for pneumonia, and one for seizure, and other medical relations. We actually had one person hit the emergency room with severe constipation. Fortunately, no full-fledged obstruction. Weight gain can be a big problem, but that's become less of a problem of late, especially with the GLP-1s. Again, with up to 6 years of treatment, we have had only 22% gain up to 7% of their body weight. Now, of these, interestingly enough, some were underweight, and we let them gain that weight as well. This is a great slide showing you how GLP-1s really change things. These are our first 40 patients on GLP-1, and this data is a little old. But as you can see at the start, and these are all people that were already on metformin, we've almost half and this is over a little over 2 years of having GLP-1s, we've almost half the obesity rate. And, we're getting to the point where people's body mass indexes are starting to normalize. The pre-obesity is a body mass index of 25 to 29. To give you context, the general population now in the US, about 50% have obesity. It's really that high, all comers in the adult population. So we're doing population-based, we're doing a little bit better. How have we done with substance abuse? We always talk about violence. And by the way, clozapine has unique properties that decrease the risk of violence. And violence does happen, but it's not always, but it's that combination of serious mental illness with substance abuse that really tends to make things a much more dangerous situation. 50% of our kids, 60 of them, were using serious substances. We're down to 8% after a year. Cannabis, also down 82%. And that's really critically important. How have we done with cigarettes? Well, in healthy subjects, about 40% will quit over a year when given the proper stuff. That's, in other words, you use the Chantix, you use varenicline, which is an agonist for nicotine. It makes you have the nicotine and blocks the nicotine that you would get from the cigarettes. With other reports with serious mental illness, the quit rate was only 15%, but we're really aggressive. As you can see, 6 out of 7 of our kids, or actually almost 7 out of 8 of our kids, were on Chantix. And then, I used some nicotine replacement. I don't know how much of that is really affecting it. We will use bupropion. Zyban has some effect also on nicotinic receptors. This is a slide I want you to dwell on a little bit. And this is preliminary data. We're going back and looking at this. Global assessment of function is just a measure of how someone is doing. Let me give you an example. The scale goes from 0 to 100. There are very few people in the 90-100 range. People like Einstein, 95. He was especially not that great socially. Barack Obama, very eloquent, very astute, very smart, 95 to 100. Our kids, on the whole, started out pretty damn good at 80, which means maybe you have a little anxiety, but you're functioning well at school. You're still a good student. This is the pre-illness baseline. This is early on. All right. Now, at their worst, their global assessment of function is 19. What that represents is universally hospitalization. They're often suicidal. They're certainly not functional. They're not working. And they're really almost always, a danger to themselves, or not almost always, frequently a danger to themselves or others. They have no function. They are not relating to their family. They have no social, and they certainly are not working or in school. The other antipsychotics do work. You go all the way up to a 38. You're twice as good as you were. But what is a 38 on a global assessment of function? Most of these kids try to go back to work, but often still fail. Try to go back to school and do okay, but are not even remotely close to where they were. A lot of these kids in the good enough are your kids you find that are not violent, are not suicidal, but are often living in the basements playing games on the computer, have lost all their friends, and are very isolated. Probably the worst part of schizophrenia is that isolation. When they came to us, they were doing better. They're up to 56. These are kids that are starting to come out of the house, starting to do better in school, starting to make friends again, starting to socialize, but still with a lot of anxiety, often with a lot of psychotic delusions and a lot of paranoia, often the voices, but functioning better. Finally, after a year on clozapine and optimized regimen, we've returned most of these kids close to the functional state that they were before. People told us we couldn't do it, but this is what we've seen. So these are the realities, guys. And these are the big 7 C's. This illness, we have to think of it differently. It is a serious brain disease, and it's really common. 3.3% of the population, if you take not only the schizophrenia, schizoaffective, and the severe bipolar illness. And cognition is a huge problem, and that I will group in with the negative symptoms. And it results in anosognosia, just the unawareness. They can't think of their own thoughts. They can't assess where they are. They're often unaware of the illness. It is enormously costly. 340 is an old number. Our more recent projection, we're doing this with schizophrenia and psychosis action line, is close to $500 billion. This is direct and indirect costs. It's a lifelong, it's chronic. Even, people say, oh, they're better. I can back off. I don't need to support them. Daniel still needs support. All of our kids still need support. It's a chronic illness. But if you don't treat it, the lifespan could be dramatically reduced. In one of my favorite studies called the FIN20 study. If you looked at people 20 years into their illness with psychosis, if they're on no antipsychotic, 46% were dead. If they're on any other antipsychotic besides clozapine, over a quarter were dead. On clozapine, it was still too high, but it was only 1 in 7 individuals. Again, none of these drugs are perfect. It's crippling, as I said. It just, these kids just are removed from their lives. It's such a cruel disease because they're removed from their lives just when they're starting them. And it is a disease of neurocircuitry. It's genetics, it's environmental, it's neurodevelopmental. You want to change the trajectory of the illness. You want to cut the inflammation down. Clozapine seems to be the only drug that we're starting to get meaningful data for that changes on a reliable basis the trajectory of this illness. There's some early studies now coming out of Mount Sinai where they're looking at gray matter loss. Again, there's normal gray matter loss as you get older. And the people with clozapine, those losses are coming closer to the normal range by far than any of the other drugs. Whoops, wrong way. So we have to rethink schizophrenia, right? We have to realize what we're dealing with. It is a neurological disease. And it really is profoundly different than what we used to think of. And we used to think, and I was told this, that Daniel's life was over. People will come up to me and say, I was given a death sentence. And we hear this time and time again. There's a good friend that I have by the name of Bethany Iser, who runs a charity called Cure SC. That was her experience. And we're having our big party in my backyard August 2nd. She will be there. We have the tents and all that. Everyone is invited. Bottom line is, we have to stop discriminating against these kids. This should be a call to action. We have to use the most effective treatments as early as we can. And we have to use a comprehensive and integrated care, right? And we have to involve everyone. There's new hope. We need to identify these things early. Cure, not my slide. It's an interesting concept. Better and almost cure-like in its control, I think, is more a real statement. So again, they begin early, prenatal life, not adolescence. Remember the prodromal illness. Early diagnosis is critical. And there's such a massive gap between what we know and what we do. We know clozapine is superior. We have the lowest use of clozapine in the United States in the civilized world. It's ashanda, which is Yiddish for shame. So we have a lot of potential. This is only the United States. This is 2016. Again, 8.3 million if you take the 5.5 with bipolar and 2.8 million with schizophrenia. Of those, as I said, almost half never get treatment. What's the consequences? Where are these kids? What's been going on? Have you noticed over the years what our cities are starting to look like? Chronically homeless people typically have serious mental illness. A study done in Miami-Dade County. In Miami, the chronically homeless, 85% had serious mental illness. Now, I admit that also included people with serious substance abuse that got grouped in there. But for all intents and purposes, people that have used a lot of methamphetamines look almost exactly like people that with schizophrenia. And if you look at their brains, they look very much the same as well. Where else are our patients that used to be housed in the sanatoriums? At its peak, by the way, the sanatoriums housed, and this is the 1950s and 60s. Then Thorazine came out, and we thought we could take these kids and move them out of the sanatorium. We had 550,000 beds. There are only 50,000 beds, chronic beds in the United States. So where are they? They're on the streets and they're in jail. What's the largest provider of mental health care in the United States? The LA prison system. Rikers is second, Cook County is third. What happens? what happens to they if they don't get good care? 50% of our population will have a suicide attempt. We've lost more recently up to 50,000 suicide deaths in a more recent year than 2015. And then we talk about violence. The reality is someone with good treatment that has a psychotic illness is not more violent than the general population. In fact, there's some data that suggests that there are kids on clozapine are less violent overall, significantly so. But since they represent only 3% of the population, and you do look at the homicides, and you know we're not treating so many of them, it's not surprising that 10% of perpetrators of homicide have serious mental illness. And when you're talking about family trauma, people say, oh, people with serious mental illness are not more violent. Well, again, if they're untreated or inadequately treated, they are. So if you look at the family and you're looking at homicidal rates, again, 3% of the population, tenfold risk, 29%. And then if you go to mass shootings, 50%. So we have a lot of work to do. It's broken, fragmented, where people are suffering. Some of the initiatives that I'm involved with, especially my Doramind people, I'm hoping to spread my approaches. I'm involved with several education initiatives, though we did get rid of one of the big obstacles for clozapine use, the mandatory blood work. We now have to educate the community on how to take care of these kids, and getting more and more people involved in that. So what are the 3 takeaways I want you to come away with this? Now, understand the population we're dealing with. Again, this is a psychosis spectrum disorder. All our kids are a little bit different, but what is in common is the detachment from reality that has led to their suffering and from their decline in their own status and in their ability to relate to others. The resistant psychosis population and those with suicidality have special relevance to us. Again, someone gets a first or second generation antipsychotic and they're hunky-dory and all better, I don't have a strong argument about continuing that. I wouldn't personally do that because, as I said, clozapine has the best data for changing the trajectory of the illness. Therefore, and what I found with the more mild psychosis. So if you look at our bipolar population versus our schizophrenia population, the dosing and the levels required to maintain clinical stability tend to be 1/3 to 1/4. So you can use lower doses, and with that, there's side effects are better. Also, understand that we do have dramatically poor outcomes right now. So we really do need to change things. And we have a treatment. It's all I'm saying is use the most effective treatment in the most effective way. Give these people what they need. There is a solution out there, and I just want people to use it. And that's my book. That's a little old, 2017. We have the book actually at the printer, just getting its table of contents now, the 5th edition. It's greatly expanded, I think. So Lou Opler, who's deceased, unfortunately, wrote this book with us. He's the gentleman that came out with the staging of schizophrenia, the serious mental illness, and looking at the positive and negative symptoms. And I wrote it with my wife, my son, and my section I expanded from about 60 pages to close to 200. And then the Clozapine handbook is very useful. A lot of synergism between the 2 books. And you'll probably get your psychiatrist to look at the Clozapine handbook, and that's fine by me. They tend not to like to look at my book because, as they are fond of saying, I am just a nephrologist. But people are listening. So that's our website. You can contact, again, I am not taking any new patients, but I am supervising the nurse practitioner. So if you're interested, I don't have this here, but Doramind, D-O-R-O, named after Dorothea Dix, mind.com. And you can get information and get help. We do care. We have the NPs with licensing in Connecticut, New York, and New Jersey at this time, and Massachusetts. And we're do our consults. We're willing to work with your psychiatrist. So that's all I got for you guys. So I'd be very glad to take questions. I thank you all for staying. I know I talk a lot, and I know I said a lot, and I hope it wasn't too much that, or too technical. I try to, give you, I don't want to quote unquote dumb it down, because I find a lot of the NAMI people have been there, have taken their family to family, and know a lot.